Welcome back to QuickIM with Dr. Aid. Today we're tackling a tough but critical topic, resistant hypertension. Ever met a blood pressure that just won't back down? Even after 3 meds? That's resistant hypertension. But don't worry, we've got a game plan. First, we'll check for sneaky causes that might be hiding. Next, we'll fine-tune your meds to find the perfect fit. And let's not forget lifestyle changes that can make a big difference. Step by step, we'll show you how to tame the toughest blood pressure cases. Let's turn this pressure into progress. Resistant hypertension is defined as blood pressure that remains above target despite using 3 antihypertensive classes, including a diuretic. Apparent resistance or pseudo-resistance may be due to factors like poor adherence, white coat effect, or measurement errors. True resistance is confirmed after excluding these factors. At the extreme end, refractory hypertension is uncontrolled despite 5 or more agents. Guidelines for diagnosing hypertension vary. The 2017 American College of Cardiology and the American Heart Association, ACC-AHA, defines hypertension as 130 over 80 millimeters of mercury and above, while the 2023 European Society of Hypertension, ESH, sets it at 140 over 90 millimeters of mercury and above. Treatment targets also differ by age group. Be sure to check which guideline your practice or board exams are using. Resistant hypertension affects 5 to 13% of patients, increasing cardiovascular risks. It's associated with factors like age, obesity, high sodium intake, alcohol, tobacco use, and importantly, secondary hypertension. Common culprits include chronic kidney disease, which impairs sodium and fluid balance, renovascular hypertension, often due to renal artery stenosis that triggers excess renin release, and primary hyperaldosteronism, characterized by aldosterone-driven sodium retention and potassium loss. Endocrine disorders like Cushing's syndrome, thyroid dysfunction, and parathyroid disease also contribute by altering vascular tone and fluid regulation. Pheochromocytoma, though rare, causes paroxysmal hypertension via catecholamine surges. Obstructive sleep apnea, increasingly recognized, leads to sympathetic overactivity and resistant BP. Other causes include aortic coarctation, acromegaly, and mineralocorticoid excess syndromes. Medications and substances, such as NSAIDs, corticosteroids, licorice, stimulants, and recreational drugs like cocaine, can also drive persistent hypertension. Patients with resistant hypertension have a significantly higher risk of heart failure, stroke, kidney disease, and mortality. Identifying these associations is key to effective treatment. A thorough and structured diagnostic approach is essential when evaluating resistant hypertension to distinguish true resistance from pseudo-resistance and identify reversible contributors. The first step is to confirm blood pressure readings using proper technique, repeated measurements, and validated devices, ideally supplemented with home or 24-hour ambulatory monitoring to exclude white coat hypertension. Next, assess medication adherence by directly asking the patient, reviewing pharmacy refill records, or considering drug-level assays. It's also vital to evaluate lifestyle and iatrogenic contributors such as high salt intake, obesity, alcohol use, NSAIDs, licorice, and drugs like cyclosporin or cocaine. Screening for secondary causes is the next step. Check serum creatinine and urinalysis for chronic kidney disease, aldosterone-renin ratio for primary aldosteronism, and renal imaging, duplex, CTA, or MRA, for renovascular disease. Test plasma metanephrins for pheochromocytoma, conduct a sleep study for suspected OSA, and check TSH, calcium, and PTH for thyroid or parathyroid disorders. Each step helps tailor a focused and effective treatment plan. The management of resistant hypertension requires a comprehensive, multi-tiered strategy that addresses both modifiable lifestyle factors and pharmacologic resistance. First, reinforce lifestyle interventions such as weight loss, regular physical activity, sodium restriction, DASH diet, moderation of alcohol intake, and smoking cessation. These changes alone can significantly lower BP and enhance drug responsiveness. Pharmacologic treatment should follow a stepwise approach, starting with optimizing the foundational three-drug regimen, which includes ACE inhibitors or angiotensin receptor blockers (ARBs), calcium channel blockers, and thiazide-like diuretic, before adding further agents. The choice and sequence of medications must be individualized based on comorbidities, drug tolerability, and suspected underlying etiologies. In difficult cases, device-based therapies such as renal denervation may be considered. It is also crucial to identify and treat secondary hypertension if present. Importantly, referral to a hypertension specialist is recommended if blood pressure remains elevated despite 6 months of optimized treatment, to ensure advanced workup, access to novel therapies, and multidisciplinary support. Stepwise pharmacologic therapy begins with lifestyle changes and rationalizing ongoing treatment. Depending on kidney function, different combinations of ACE inhibitors or ARBs, calcium channel blockers, and diuretics are used. Additional agents are added if blood pressure remains uncontrolled. Now, let's dive into the step-by-step approach. The initial 3-drug regimen for resistant hypertension, comprising a renin-angiotensin system blocker, such as an ACE inhibitor or ARB, a calcium channel blocker, and a thiazide or thiazide-like diuretic, preferably chlorthalidone or indapamide, is based on complementary mechanisms that target key pathways in blood pressure regulation. RAS blockers reduce vasoconstriction and aldosterone-driven volume expansion. Calcium channel blockers provide vasodilation by acting on vascular smooth muscle, and thiazide diuretics decrease plasma volume and sodium retention. Using these agents at maximally tolerated doses ensures that patients receive optimized therapy before labeling the hypertension as resistant. This structured approach, endorsed by the American Heart Association's scientific statement and European Society of Cardiology and Hypertension, helps rule out pseudo-resistance. This combination at maximally tolerated doses is crucial before diagnosing true resistance. Cautions and contraindications are vital in managing resistant hypertension. ACE inhibitors and ARBs are contraindicated in pregnancy. Calcium channel blockers may cause peripheral edema, and thiazide-like diuretics require caution in gout and advanced CKD. It is important to note that thiazides and thiazide-like diuretics are less effective in advanced CKD, especially when eGFR is less than 30. Consider using loop diuretics instead in this situation. Mineralocorticoid receptor antagonists, or MRAs, such as spironolactone and eplerenone, play a pivotal role in the management of resistant hypertension, defined as uncontrolled blood pressure despite the use of 3 or more antihypertensive agents, including a diuretic. MRAs target aldosterone-mediated sodium retention and vascular inflammation, which contribute to persistent hypertension, particularly in patients with high aldosterone levels or low renin profiles. The Pathway 2 trial demonstrated that spironolactone was superior to other add-on agents like beta blockers or alpha blockers in lowering blood pressure in resistant hypertension. MRAs are especially effective in patients with primary aldosteronism or evidence of volume overload, though their use requires monitoring for hyperkalemia and renal function. Current guidelines, including those from AHA and ESC, recommend MRAs as the preferred fourth-line therapy in resistant cases. Eplerenone causes fewer anti-androgen-related side effects compared to spironolactone. Note that mineralocorticoid receptor antagonists are considered first-line medical therapy for patients with primary aldosteronism who are not candidates for surgery, such as adrenalectomy, or who decline it. Beta blockers are generally not recommended as a first-line treatment for hypertension, especially for routine initiation. In resistant hypertension, where other medications have been tried, beta blockers, especially vasodilating beta blockers like labetalol, carvedilol, nebivolol, are considered as a potential fifth-line agent. However, they are a useful part of the treatment regimen for resistant hypertension, particularly in specific situations like post-myocardial infarction, heart failure with reduced ejection fraction, and for heart rate control. For managing hypertension in pregnancy, labetalol is a commonly recommended first-line medication. Some beta blockers can have adverse metabolic and lipid effects. Vasodilating beta blockers may have a more favorable metabolic profile. Other unfavorable effects include fatigue, depression, or sexual dysfunction. Avoid non-selective beta blockers in patients with severe obstructive lung disease, like asthma and COPD. Choosing between selective and non-selective beta blockers depends on the clinical scenario. Non-selective beta blockers with alpha blockade, like carvedilol and labetalol, are preferred for significant blood pressure reduction, while selective ones are better for heart rate control. Non-selective beta blockers are generally avoided in patients with severe obstructive lung diseases such as COPD and asthma, where cardioselective beta blockers are preferred due to their reduced risk of bronchoconstriction. Common alpha blockers include doxazosin, which is long-acting and usually dosed once daily, as well as prazosin and tamsulosin. Alpha blockers are particularly useful for patients with benign prostatic hyperplasia, BPH, and can be considered as an adjunct option when blood pressure remains uncontrolled despite using 4 to 5 other agents. They work by blocking alpha-adrenergic receptors, leading to vasodilation. Caution is advised for orthostatic hypotension and fluid retention. Central acting agents, emphasizing the use of clonidine and methyldopa in treating resistant hypertension. Clonidine is a powerful central alpha-2 agonist that effectively lowers blood pressure, but is often limited by side effects including dry mouth, sedation, and the risk of potentially dangerous rebound hypertension if the medication is stopped abruptly. Methyldopa, another central acting agent, remains a preferred and well-established treatment for hypertension during pregnancy due to its safety profile. Both drugs are typically reserved for refractory cases when other antihypertensive therapies have failed or are unsuitable. Adjunctive therapies include direct vasodilators like hydralazine and minoxidil. These are used in refractory cases and often require co-prescription with beta blockers and diuretics. Long-term use may lead to specific side effects. Hydralazine is given with nitrates in patient with heart failure for mortality benefit. Long-term use of hydralazine may cause drug-induced lupus. Minoxidil is known to cause pericardial effusion, hirsutism, and reflex tachycardia. Emerging therapies for resistant hypertension include aprocitentan, a dual endothelin receptor antagonist, and SGLT2 inhibitors. These novel agents offer new options for patients with true resistant hypertension after multiple drug failures. To summarize, the pharmacologic management of resistant hypertension follows a stepwise approach, starting with the optimized use of 3 core agents: an ACE inhibitor, or ARB, a calcium channel blocker, preferably a dihydropyridine like amlodipine or nifedipine, and a thiazide-like diuretic such as chlorthalidone or indapamide. If blood pressure remains uncontrolled, a mineralocorticoid receptor antagonist, MRA, typically spironolactone, is added as the preferred fourth-line agent. Beta blockers, especially those with alpha-blocking properties like labetalol or carvedilol, and alpha blockers like doxazosin can be used in selected cases, such as those with comorbid heart failure, CAD, or BPH. Central acting agents like clonidine or methyldopa and direct vasodilators, hydralazine, minoxidil, are reserved for refractory cases due to side effects. Newer agents such as SGLT2 inhibitors, finerenone, and the endothelin receptor antagonist aprocitentan offer additional BP-lowering benefits, particularly in patients with CKD, diabetes, or true resistant hypertension. Device-based therapies, such as renal sympathetic denervation and baroreceptor activation therapy, offer alternative options for resistant hypertension. These devices target sympathetic nerve activity to reduce blood pressure. Managing treatable secondary hypertension involves identifying the underlying reversible cause and implementing targeted therapy that often leads to significant blood pressure improvement or even cure. For example, primary hyperaldosteronism may be treated with mineralocorticoid receptor antagonists like spironolactone or eplerenone, or with adrenalectomy if due to an adenoma. Renovascular hypertension from renal artery stenosis may require angioplasty, stenting, or medical therapy, depending on severity and kidney function. Obstructive sleep apnea, OSA, should be addressed with CPAP therapy, which not only lowers BP, but also improves cardiovascular outcomes. Pheochromocytoma mandates surgical resection after adequate alpha blockade, while thyroid or parathyroid dysfunction requires appropriate endocrine management to restore metabolic balance. Additionally, stopping or substituting BP-raising medications, like NSAIDs or corticosteroids, can also resolve or improve hypertension. Successful treatment of these secondary causes often leads to better long-term BP control and reduces the need for polypharmacy. Key takeaways include regular blood pressure monitoring, ruling out pseudoresistance, and evaluating lifestyle factors. Sequential drug titration and patient education are essential for effective management of resistant hypertension. Thanks for watching. If this helped you, don't forget to like, share, and subscribe to QuickIM with Dr. Aid for more high-yield, real-world clinical teaching. See you in the next one.